Just want to start off by acknowledging that I do have some research grants and some academic book royalties. The place I want to start is by reflecting on these data. In most of our countries, about 3 in 10 of us will meet diagnostic criteria for a mental disorder over any 12-month period. And these are not trivial problems. They're way up there with the leading causes of disability. Suicide, which is often associated with mental health challenges, is a leading cause of death. And these publications in The Lancet in 2013 tell us that it looks like the rate of mental illness is increasing globally. And of course, since then, the COVID pandemic has resulted in a deterioration in mental health in terms of certain subgroups in our communities. Now, I know that this audience, you all, don't need to probably be convinced about this, that sleep and circadian disturbances contribute to mental health challenges, and mental health challenges make it difficult to get to sleep, stay asleep, and maintain a regular schedule. And so this bi-directional escalating vicious cycle has been a core interest that we've had. And our starting point for this interest was working with individuals who met diagnostic criteria for bipolar disorder, which we know can be a serious problem for people, with episodes potentially lasting several months and the rates of suicide being quite high. And sleep and circadian symptoms are very prominent correlates of episodes and impairment even between episodes. So when we first came into the field, a bunch of colleagues said, I don't think sleep and circadian disturbances in bipolar disorder are anything more than just an epiphenomenon to the other things going on in this disorder. But we decided to press on, mainly because these scholars in the field already were publishing, we thought, some very convincing work on the importance of sleep and circadian disorders and problems in bipolar disorder. And there was also this meta-analysis that had been published showing that sleep disturbance is a common prodrome of episodes in bipolar disorder. Moreover, there were many daily diary studies being conducted, including some from my group, showing that sleep loss is tightly coupled with daytime mood in bipolar disorder. And there were just a few sleep deprivation studies showing that sleep deprivation triggers hypomania or mania in a proportion of patients. So in deciding what to bring along today to share with you, I decided to bring along 2 findings that pushed our thinking in new ways. So these findings both came from the STEP-BD data set, which is a publicly available data set based on over 2,000 people who had been diagnosed with bipolar disorder. And the first finding that kind of made us pause and think, this is pretty important, was when we looked at variability in sleep and wake times across 1 week, and we saw that the variability was about 3 hours. So consider that for a moment. Consider where you live and somewhere that's a 3-hour time zone difference from there. So right now I'm living in the San Francisco Bay Area. And last week, I had to fly across to Canada for the Canadian Sleep Society meeting. And that was just a 3-hour difference on one occasion. You know, I got sick. I didn't feel good mentally or physically. And that was just one time zone difference. Who knows exactly what the causal factors were there. But I think the point is there that if we do this on a weekly basis, as it appears people with bipolar disorder may be doing, we're going to create some vulnerabilities in terms of mental health and probably physical health. Here's another finding that struck us as really important from this data set. We compared people who were getting a solid 6 to 9 hours of sleep a night, and we looked at their mood profile cross-sectionally, and we compared them with short sleepers. The first thing to notice, so these are people below 6 hours of sleep. The first thing to notice is that in this sample, there are a lot of short sleepers. And in terms of the mood profile cross-sectionally, people are more likely to be depressed and more likely to be elevated. So that was interesting. We kind of already knew about this group in the literature already. But what we weren't so clear about, and we really started to make a priority, are the long sleepers in this sample. So notice a big group again, and long sleep was not better, at least cross-sectionally. People were more likely to be depressed. Now, we could spend, a whole day talking about the mechanisms that might be contributing to the long sleep group and the short sleep group at various levels of explanation. And maybe we could think about that together in question time. But at this point, what I want to point out is this was way more complicated than we were expecting. We were insomnia researchers coming in and fully expecting to help people who were diagnosed with bipolar disorder with insomnia. But what we're actually seeing is a range of different sleep problems. And actually, since then, we've been seeing a similar pattern of findings across mental health challenges, be it schizophrenia, be it depression, anxiety, eating disorders, and so on. So we became intrigued by the idea that maybe sleep and circadian disturbance might be a modifiable pathway that might be able to cut in to this vicious escalating cycle and make a difference for these kinds of outcomes. And so we set about testing that idea. We call this a treatment experiment. You can do an experiment with sleep in two ways, I guess, or more than two ways, but, sleep deprivation or sleep improvement. And I think when it's a group who are already vulnerable and particularly vulnerable to the effects of sleep deprivation, we might want to do the causal experiment to increase sleep in this group. So we tried to do that. So this, we decided, given the complexity of the sleep and circadian problems, to open up the inclusion criteria. We were originally funded to do this on people who met diagnostic criteria for insomnia, but given our prior work, we realized we're going to have a hard time recruiting because people tend to have a lot of other problems in addition to insomnia. So you can see this is a very small pilot study that's more about learning than confirming. And we randomized people to either get CBT for insomnia that we adapted for bipolar disorder, or a psychoeducation control group. And we followed people up 6 months later. This is the primary outcome for this study. You can see in the red is the group who got CBTI adapted for bipolar disorder, and in the blue are the group who got psychoeducation. And actually, both groups improved, but the improvement was significantly greater for the group who got CBTI adapted for bipolar disorder. Specifically, you can see a reduction from before the treatment to after the treatment and through to 6-month follow-up. Same pattern of findings for the Sheehan Disability Scale, but this time the two groups did not differ. So I always like it when the control group does well too. About relapse for the 6-month follow-up period, Here in the red, you can see the lower rates of relapse in the group who got CBTI adapted for bipolar disorder. So this is super interesting, right? And actually it converges with a bunch of other studies showing that if you give people CBT for insomnia, it does improve sleep and the symptoms of the comorbid mental disorder. So I just showed you that data for bipolar disorder. I could show you that similar, very, very similar data for youth who were depressed. But in both of these cases, we had to adapt cognitive behavior therapy for insomnia for these particular disorders. And groups around the world, and this is not, there are many other groups doing this work, and some meta-analyses showing a very similar pattern of results. So this is wonderful. It does look like intervening on sleep is a modifiable pathway to improving mental health. But I wonder if we could do better. As I mentioned, well, I haven't mentioned this bit yet, but let me mention it now. All of these studies are focused on insomnia, but as I mentioned a moment ago, and I'll show you some I think, strong data, the real life sleep and circadian problems that people are experiencing are just not that easily categorized. In fact, people are experiencing lots of other full and subsyndromal features of a range of different sleep and circadian disorders. So we sort of wondered, what do we do with all of this complexity? We could continue to develop, specific single disorder variants of CBTI, CBTH, CBT for hypersomnia, CBT for other kind of versions of sleep and circadian problems. For us, we decided to hold off that because John Weiss, Bruce Torpeda, and others, looking at evidence-based psychological treatments broadly, not just sleep and circadian treatments, but, treatments for depression, anxiety, DBT, CBT, ACT, etc. We actually have hundreds of these treatments. And we now refer to this as the too many empirically supported treatments problem. Now, it might seem like a great problem to have, but actually it places an immense burden on clinicians in routine practice settings who have to learn multiple single disorder protocols. And that ultimately makes it difficult for people to get the kinds of treatments that they need. So we decided we should try something different. We thought, well, maybe we could develop one treatment that reverses the maintaining processes that are in common across sleep and circadian disturbances, across mental health diagnoses, and maybe even across some phases of development. I'll show you some data on youth as well as adults. Now, if this were possible, it would be hugely advantageous for dissemination because there'd be a cost advantage to training providers in one treatment that covers multiple problems, particularly in low resource settings, like some of the settings we're working in. The first version of this, and colleagues all over the place are doing interesting things with this and creating new versions of it, new modules for it. But the first version was called the Sleep and Circadian Intervention for, the Transdiagnostic Intervention for Sleep and Circadian Dysfunction. Now, we're a treatment development team, and when we go about developing a new treatment, we try to do so with the utmost rigor. So we grounded this approach in the basic sleep and circadian science, in the sleep health framework, and we drew principles from current evidence-based treatments. Now, let me just give you a very brief taster of each of these. First of all, which parts of the sleep and circadian science did we ground this in? Well, the idea here that we got very intrigued about that I've mentioned is this complexity. And we wondered what this complexity is doing at the level of the biological clocks. We know there are clocks in every cell and organ in these bodies of ours. There's the central clock, the suprachiasmatic nucleus, that's highly sensitive to light and dark. But there are clocks in every other cell and organ, but they synchronize to a variety of stimuli and at their own rates. But they interact with all of the other clocks. So unless we have conditions of regular bedtimes, regular wake-up times, appropriate exposures to light and dark for the species, then this orchestra of biological clocks will be out of tune. But if we can get regular bedtimes, regular wake-up times, appropriate exposure to light and dark for the species, this orchestra of biological clocks should be in tune. And so we wonder, in problems like bipolar disorder, schizophrenia, depression, if there's a double desynchronization, whereby there's desynchronization between internal time and external time, and within the body, and between all the different clocks and organs in the body itself. So there's a clinical implication right here, right, too. And these are fundamental in the transdiagnostic approach to sleep and circadian problems. One is try to help people to develop habits of light exposure that will hopefully last a lifetime, of dim lights in the evening and bright lights in the morning. Now, this is not an easy habit for lots of humans to develop. And I think it's fairly skillful to help people to develop those habits. So I'll talk about that in a moment. The other habit we want people to develop here is regular bedtimes and regular wake-up times. So that's one part of the sleep and circadian science that we've been kind of carefully thinking about, and, drawing from the beautiful work of people like Anna Weir Justice and other people over in your neck of the woods. So Bourbe's two-process model, also very interesting in this process. We know that process S and process C are separable systems. They interact. I don't think we know yet, correct me if I'm wrong, about the specific contribution of these two systems to problems experienced by, say, people diagnosed with bipolar disorder. But what we do know is that these systems are preferentially open to certain exogenous inputs. And if you cast your eye down these exogenous inputs, they're modifiable with the kinds of behavior change interventions that we all know how to do. So that's just a little taster of the sleep and circadian science. And actually, I should have said, so this is exactly what we do in the transdiagnostic treatment. We try to target these factors, these exogenous inputs that evolution has endowed us to be able to modify. And we use behavior change interventions to be able to do this. So another basis for treatment development is the sleep health framework. Now, there's actually an acronym here, RU stated with sleep. So the emphasis here is not on sleep disorders or circadian disorders. The emphasis is to say, go much broader, to think about getting humans sleep health across these 6 dimensions. We should be getting humans regular sleep, satisfying sleep. They should be alert in the day. The timing of their sleep should be appropriate for the species. They should be spending only enough time in bed for sleeping and not a whole lot of other time in bed where they're not sleeping, such that they have efficient sleep and they're associating the bed with sleep, not with waking. And they should have sufficient duration of sleep, and that is sleep health. So that is a focus in the transdiagnostic treatment, to be making progress across these 6 sleep health dimensions. So, there's so much more to say about the development of this treatment, but there's not enough time. So I want to go on and just say, for carefully constructed reasons that I can go into in question time, this ended up being a modular treatment. And what that means is that there were cross-cutting modules that are important across sessions. There are core modules that are the basic building blocks for sleep health for everybody. And there are optional modules that we bring in depending on the specific problem that each person is experiencing. And just to draw your attention to, a lot of people we have found who have a mental health illness also have sleep apnea. So we have protocols in this approach to help people to get treatment for sleep apnea and then help them to adapt and adhere to sleep apnea treatment. We also find that a lot of people have pretty complicated sleep environments that are not necessarily conducive to good sleep. So a lot of this is working with people at the kind of behavioral level of explanation. So the first test of this was done with night owls. These are adolescent night owls. And we went for this group for a couple of reasons. One is when we did our study on teenagers with depression and insomnia, we had to exclude so many teenagers who wanted to be in that study and desperately wanted treatment. And most of them were night owls. They didn't meet criteria for insomnia. They were clearly distressed and they wanted treatment. So that's a first reason. There was a group in need. A second reason is that being a night owl is surprisingly correlated with a whole bunch of mental health symptoms. And now there are some non-replications, and a lot of these are cross-sectional studies. There are some longitudinal studies, though. Now, I wanted just to kind of see, give you a snapshot of the kind of people in this study. This is a typical afternoon for a young person in this study. Arrive home from school, have an afternoon snack, often high sugar content, enjoy their high, crash into a 90-minute nap, groggily wake up, do some YouTube, do some gaming, squeeze in some dinner at some point, start on homework, lots of multitasking, more YouTube, more gaming, head for bed late, like 1 a.m. And then a lot of difficulty getting to sleep, lots of thoughts like, I haven't completed my homework, and anxious thoughts. And that game was pretty fun and sort of like excited feelings. And then sort of more ruminative thoughts, like, I wonder if Peter likes me, and then kind of reaching for the cell phone to see if Peter has texted. And then wake up time for school is really early, at least in America. I hope that in Europe, it's not like this. But, there's a lot in here that's modifiable, again, at the behavioral level of explanation. So that's a target in the transdiagnostic treatment. So here's the design of the treatment. This was 10 to 18-year-olds, and everyone was randomized to get the transdiagnostic treatment or to get psychoeducation. And the psychoeducation treatment's a pretty strong control group. Here's the first primary outcome measure. This is a self-report measure of morningness and eveningness, whereby higher scores are indicative of morningness and lower scores are indicative of eveningness. And you can see we got a significant interaction, and actually in both groups, there was a move after the treatment, as you can see in orange, toward morningness. But this move toward morningness was greater for the group who got the transdiagnostic treatment. And if you haven't already picked up, we're very interested in habit formation. Do the gains maintain? In this case, the gains did maintain. Total sleep time, we didn't change anything. Huge bummer. Huge disappointment. Why? Oh, wait, we did. The next one we didn't change. In the transdiagnostic group, we increased total sleep time, but this was not maintained. We did not manage to bring the bedtime forward, though. And I wonder if bedtime is not the thing to be measuring at this point. Exelman and colleagues over in Europe said in the Journal of Sleep Research, and I think there's really something to it, that in this day and age where people are using technology in bed, we probably shouldn't be using bedtime as a key metric. We should be using shut-eye time. So maybe that was a mistake we made here. We did take dim light melatonin onset in the lab before and after the intervention. We got a significant interaction, and the direction of that seems to be that for the group who got the psychoeducation, there was a delay toward a later DILMO onset after the treatment, while there was an advance in the DILMO onset for the transdiagnostic group after the treatment. So this is curious, interesting, right? Is it possible that giving the transdiagnostic treatment buffered against DILMO delay that would have otherwise occurred? This is my favorite finding. You know, in teenagers, there's a big sleep in often on Saturday and Sundays through to midday or 1 a.m. Now, if you go to bed at 1 p.m., I should say, you're not going to be able to get to sleep on Sunday night, and you're not going to be able to wake up for school on Monday morning. And that delay, social jet lag is not going to go away on Tuesday and Wednesday. So were we able to reduce the discrepancy in this intervention study? We have the daily sleep diary before and after treatment, 6 months and 12 months, so we can look at this. And the discrepancy is reduced for the transdiagnostic treatment, but not the psychoeducation treatment. This was maintained through follow-up, and the sort of amount that it was maintained by compared to baseline was a reduction in the discrepancy by about 30 minutes for the transdiagnostic group, whereas the psychoeducation group, their discrepancy got bigger by about 25 minutes. So this is one of these things that I've got very interested in. You know, at the end of our treatments, is it the case that people keep using the behaviors that we have taught them? And when we asked this sample of 10 to 18-year-olds, are you still using these sleep health behaviors? They said, yes, these are the ones we're using. And if you scan your eye over these, you will see that they're good ones to be using. But when we ask them, how often are you using these? The majority of people say occasionally. So that's not at all what we want to see, right? And that actually triggered us to seriously study the science of habit formation. We have a Perspective in Psych Science article and a new grant where we're looking to see if we infuse the science of habit formation in our sleep and circadian treatments, can we make a bigger impact on sleep health? And at this point, I want to share this email that an adult patient sent over. This is a patient who had participated in 8 sessions with us, 8 sessions. This is someone who met diagnostic criteria for bipolar disorder. It's very interesting. She said, I've checked in with you mentally every single day. I don't even like pushing my bedtime back to 12:30. It just doesn't feel good, not in terms of rest and not in terms of this habit energy I've developed around an 11:30 bedtime. I really, truly developed some strong positive habits. They are ingrained. Habit formation has taken place, but how do we bottle down what happened? between this client and Dr. Kate Kaplan when they did this treatment. And, let me ask you, what are the habits that you would like patients who have sleep and circadian problems to develop? And also, what about the habits you'd like the general public to be developing? And also be thinking about guesses as to one or more of the ingredients of effective habit formation. We can talk about these if people are interested in the Q&A. This is the science of habit formation. And actually, we know a lot from social psychology and other disciplines about what habit formation involves. So it involves 3 ingredients. The first one is a pairing between a cue and a behavior. So we see this here. The cue is a time clock cue, 10:30 p.m., and the behavior is I'm going to be winding down at 10:30. Here's another cue, 11:30 p.m. I'm going to be winding down. It's bedtime at 11:30. So that's a cue behavior pairing. The second ingredient is practice. In the habit formation literature, we see that actually it takes between 18 days and 9 months for people to develop a habit, depending on the complexity of the habit. So people need a lot of time, potentially, to develop habits. Third ingredient, they need a reward. And we see this, an intrinsic reward. The patient says, it's much more comfortable for me to stick to my routine than not to. I like being home and winding down at 10:30 p.m. So how do those of us here who work with patients, those of us here who are doing animal research, those of us here who are interested in the behavioral level of explanation, help to make progress on infusing the science of habit formation into the sleep and circadian work that we do? Now, if we can help people develop a cue, help them realize they've got to practice, and help them identify the intrinsic reward, we have automaticity. The habit develops automatically. And we see this here in terms of the patient. She says, not in terms of rest and not in terms of this habit energy. I have developed an around 11:30 p.m. bedtime. I really, truly developed some strong positive habits. They're ingrained. So this is the science of behavior change that I'm talking about here. I want to give you one more example. Habit formation is one example. Here's another example. This was embedded in the literature. It's an abstract. We just saw it and we thought, wow, this is important. It was showing us that adult insomnia patients only remember 1/3 of the content of treatment, and recall was actually as low as 13%. Surely people have to remember the treatment in order to adhere to it and in order to improve. We replicated this. People with bipolar disorder we treated for insomnia only remembered about 1/3 of the treatment content. Other literature shows that memory is particularly poor for health behavior change advice, and that it's not only that people don't remember, they actually recall things, recommendations that were not made. This is a study that we very recently published. When we add memory support to treatment as usual, people adhere to treatment better, and that improves outcome. So then the question becomes, how do we improve memory for treatment? And in the cognitive science literature, in the education literature, we know that simply just repeating the content you want people to remember is good. So when I take my young son to the pediatrician, and through our masks, she sort of says, and there are 4 things I want you to remember this year. And she tells me, repeats the content of what we discussed. I remember those things. She says them with some drama, and it helps me remember. But there are some even better questions. So the first question is an application question, ask people, what might need to change in your life to apply these ideas? And we can help them set up a cue. What might cue you to adopt these recommendations? So this is interesting too. This is a science of habit formation, and I actually think it has a lot of promise for improving engagement in sleep health behavior, hopefully for life if we're paying attention to habit formation. And this could make a profound impact on mental health. And I've given you 2 examples. There are tons of others I hope you're working on, and please keep me in touch with the kinds of things, habit formation things and sleep science of behavior change you're working on. This is one I just ran across like 2 weekends ago. This group are working on beliefs about healthy sleep habits. Very interesting, another version. In the last few minutes, I want to develop one more theme. There's this huge gap between science and practice. So it's bad news, Only a tiny proportion of the treatment innovations any of us are working on will ever get used in routine practice. And actually, those that do get used, the lag between the development of the intervention and then being incorporated into practice is about 15 to 20 years long. It's a huge gap. I think part of the problem is that treatment development researchers like myself tend to think if we build it, they will come. Actually, this is not true. And this has spurred a whole new science that's flourishing and is gaining a lot of grant money, a lot of interest, implementation science. And there's certainly some terrific examples of implementation science in our field. I want to talk very briefly about the implementation science work we're doing. We kind of came to this by accident more than a decade ago when we realized, the representativeness of the samples we can recruit to our university clinic was really poor. We live in a very diverse region here in the Bay Area, but we have a lot of difficulty recruiting people, particularly people who are from an ethnic and racial minority. And so we started to ask ourselves, who is not comfortable attending a university clinic for treatment, and what are the barriers? So we decided to move an arm of our research out into community mental health centers. Now, this means something very different in different countries. So let me tell you just a tiny bit what it means in America. These centers have been referred to as truly unique national assets. They came about in the 60s through Lyndon Johnson's War on Poverty to eliminate health disparities. And they came about to serve many Americans, particularly people who are not insured. Remember, the US is a very different healthcare system. There are many, many people who do not have health insurance at all here. And these were built to serve low-income people. So they're a very important source of treatment. They're very under-resourced. Providers carry a huge load, and they may not have training or supervision in evidence-based psychological treatments. And certainly when we came in to work in a network of community mental health centers in California, there were no sleep and circadian treatments other than medication options. And psychiatrists were very keen for us to do the transdiagnostic treatment, because if they don't have to medicate for sleep, they don't have to deal with drug interactions. They can be focusing on the mood stabilizing medications or the antipsychotics. So lots of kind of good things seen from the community mental health partners. So this is a snapshot of the 121 people who are adults who were diagnosed with a mental health problem. You can see the primary diagnosis here, and you can see the demographics here. So in this study, people either got the transdiagnostic treatment combined with usual care delayed treatment in the red, or they got usual care delayed treatment and they got trans C later. So they're in the blue. And you can see on our primary outcome measure in the red, people improved on sleep from before to after the intervention, and this was maintained through 6-month follow-up. And this pattern of findings held for psychiatric symptoms. So in other words, if you treat people with the transdiagnostic treatment alongside usual care, you will improve psychotic symptoms, manic symptoms, symptoms of depression. And the secondary outcomes, psychotic symptoms, various sleep diary data, various other metrics were also very encouraging. Last slide, I think I want to show you the comorbidity data. We had administered a semi-structured interview to diagnose sleep and circadian problems. Now, it's self-report, so we can't diagnose narcolepsy, sleep apnea, REM sleep behavior disorder, so they're not included. We also used a 7-day sleep diary. Very, very profound, I think. Less than 10% of the sample met criteria for just one sleep or circadian diagnosis. In other words, greater than 90% of people met criteria for more than one sleep and circadian diagnosis. And on top of that, people were meeting criteria for subsyndromal diagnoses. That is, diagnoses that they didn't meet the full criteria for, they missed out by one symptom. We thought, whoa, that's really complex. What if we looked disorder by disorder? Would it get much simpler? And actually, schizophrenia, there were 39 distinct sleep and circadian full and subsyndromal diagnostic combinations. And this really adds to the growing recognition of massive heterogeneity within diagnoses. And of note, people did really well in the transdiagnostic treatment. So I am going to skip that last project and summarize. So I've described how we've moved from working in a disorder-focused way on bipolar disorder to working transdiagnostically. I've also argued that sleep and circadian functioning is a modifiable pathway to improving mental health. I've shown you data supporting that. I've argued that at least in some context, there may be a mismatch between the comorbidity and the complexity of the problems people are experiencing and the treatments available. And I think there's value in working at the behavioral level of explanation, in trying to promote engagement in sleep health behavior through a science of behavior change lens, and conducting research within routine practice settings. Here in America, a lot of research is conducted in academic medical settings, and not everyone has, well, many people do not have access to participating in research in those settings, and they might not want to. But if we embed our research in different kinds of settings, we can get very different windows into understanding problems in new ways. Throughout my talk today, I've shown you the picture and put the name under lots of people who have been part of the team who are doing this research, and I want to thank them all. I also want to thank all the people on this slide. And now I want to thank you all for your attention, for being here today. And I want to hear from you about questions you have, about comments you have, about missed literature, anything at all. I would love to hear your feedback, think with you about things. Thank you.